Thanks, Camille. And so also just to bridge this with the previous one, as Camille mentioned, one of the areas that I work on is very much like those digital tools that Deborah and Suchi were describing. I've built algorithms myself. I tend to take a control systems perspective on it. And in particular, something that really happened with me is when I was building this is, probably like 5 years ago, I started to have this realization. Suchi brought up this idea of an optimization function. Another way you can think about it is basically saying, what is success? And I realized I was defining success for the people I was trying to help, and I didn't ask them. And that bothered me. And I started thinking a lot about, rather than, you can think of the old adage, you can either, if someone is hungry, you can either give them a fish or teach them how to fish. I started to spend a lot more of my time figuring out how do I teach people how to fish. And that's got me down this pathway that I'd like to tell you about, citizen and personal science. So, and first, before I say this, I really see what I'm doing here less as a speech for the work I'm doing and instead as advocacy work for the work that others are doing, particularly Gary Wolf, Dana Lewis, Matt Ball, and others. So first, I want to basically answer 3 questions here. What is citizen and personal science? Why does it matter? And what should the NIH do about it? Okay, so first, what is it? Citizen science, I bet you have some awareness of, and Camille already teed it up, right? It's basically the public engagement in scientific research. So think the Audubon Society monitoring birds and things of that sort. And this has been extended into health as well. But I want to get into there's a lot of dimensions to this, as Camille was just getting at. And so I want to drop an opposite extreme possibility of this, which is this idea of personal science. There's a lot of labels, but that's one that's kind of growing out. What is personal science? It's basically people using the scientific method to ask their own questions and to help themselves get answers. So what kind of questions? Things like, wait, are those really side effects? Why am I breaking out? How well am I recovering? What can I safely eat? These are important questions, right? And coming back to that optimization function, and also building on a question that Dorothy brought up about inequities, right? A really important question that we need to be thinking about is power, privilege, and who has the right to say what is success? And is it okay for people to be able to ask these questions? And how can we support them in doing it? But I'll come to that in more depth soon. But personal science is this other one. So let me just kind of give it to you, though, in terms of dimensions to try to help you see this in a 3-dimensional space. So one way you can think about this would be stuff whereby this work is professional-led versus co-developed versus work that's totally citizen-led. Another dimension you can think about this could be work that is to benefit science, work that is meant to benefit historically marginalized populations, and then work that might be meant specifically to help the communities and individuals themselves. A third dimension you might want to think about, getting out of just healthcare, of course, diagnosis and treatment in healthcare, but then also prevention, but then also enabling health, putting on my public health hat for a moment, right? So these are many different dimensions and variations, and there's a great diversity going on with this, right? So let me give you some concrete examples of this. The one that is most analogous to citizen science, as you might classically think about, is Foldit. Foldit is basically a project where professionals have built a game to allow people to work on proteins and protein folding to basically improve that, right? Another one you could think about is Propeller Health. What they've done is they built simple digital tools to pick up on pollution and asthmatic symptoms, and start to understand how pollution and asthma is interrelated. Another example, when you start getting a co-development, is Maker Nurse. This is a project where basically nurses who had all this lived wisdom and expertise, they started making and designing for themselves, but in collaboration with others, and then sharing it. An extreme one that I'd like to discuss, maybe not extreme, I'll come to why that in a moment, but one that I think is one that you might not be aware of is OpenAPS. And this was developed by my friend Dana Lewis, who I mentioned before. Long story short, Dana is not trained as an engineer or scientist, but she does have type 1 diabetes. And she ended up building her own artificial pancreas system, open sourcing it online, and now there's about 2,500 people or so that are using the rig that she developed. Not only that, but this community has done great work where they are contributing to scientific knowledge with peer-reviewed publications, challenging questions and assumptions around issues like insulin sensitivity, and they also arguably sped the pace with which FDA approval for artificial pancreas systems actually occurred. So this might sound like an extreme use case, but not really. There are many, many different examples, and if you're not aware of this, that's what I wanted to first get you to aware. There's a great, crazy level of diversity going on in this space. So that's what's going on. Let's get into the why. Why does this matter? Well, I think there's basically 3 things for us to think about. What's the implication for us as scientists? What's the implication for what we think we know? And then what is the implication for how we do our work? First, It allows us to see some possible biases of our professional science. First, stereotyping. Just think for a minute, how many different identities do each one of us hold? You know, are you a patient? Are you a professional? Are you a DIYer in some way? Probably a lot of us hold lots of identities. When we treat someone as a research subject, and I am using that in a very literal sense, not because it is good, but to think of that as a logic that we start from, we're putting people into a bucket, particularly when we call them a patient, and we're asking them to literally wait for service from us, right? And the second layer, this gets even more dangerous do you guys know the concept of the omission bias? This is a bias whereby if there is something that is potentially risky, we will bias towards inaction versus action. But of course, inaction can have its own same risks, right? So particularly if you then say I don't know if you should wait for us, but wait until we figure it out and we are 100% certain, think about the dangers we might be setting up within that. And then third but not least, could potentially set up a problem of learned helplessness, such that some people are basically said, stop, wait, and we never get to you, particularly if you have a rare condition that doesn't fit within one of the large NIH financial structures. So, first thing we need to do is just sort of check ourselves on the biases we're bringing in as scientists. Second, it raises interesting questions about scientific consensus, the foundation of science, right? Why? It basically comes down to, this is a formalism from Boaz Miller, philosopher of science, where he framed these three orthogonal characteristics. First, calibration. You have to agree that you want to agree, so ontologies and languages. But then the other two are all about diversity, diversity of methods and diversity of people. And why does that matter? Well, it's pretty easy to think about it. If you don't have diversity, you can easily calibrate to each other, but it's just because you're being homogeneous, right? You have no disagreement to actually land on something. And so if we have systematically cut out voices and methods that are feasibly valuable and help us to better understand ourselves, that is a fundamental problem that we need to think very carefully through. Last, it also asks us to start going beyond pure science into perhaps ought thinking. And for those of you who know David Hume, I'm very consciously building on his is-ought frame. And so if you're not sure what that is, let me give you an example. Imagine you are a slave owner and you look around at your land and you see that all these slaves have their food, their clothing, their shelter from you. And so therefore, you come to the conclusion that you ought to be their slave owner. Of course, that is not correct, right? David Hume was very famous on setting up that bridge between is and ought thinking is exceptionally difficult. And we are getting into a place where a lot of times these questions of what is the right world, how should the world ought to be, that's what, in many ways, these citizen and personal scientists are engaging. They see a different world that we don't necessarily exist. But we're bound into a lot of our work is around is logic, which is basically setting up science. It's fact-based. And this is really critical. It's focused on the past and present, coming to those biases, those systematic biases, where you're going to do the data, you're going to see the past, and then you're going to assume it's going to be like the future, right? Ought thinking is different. It's about ethics and its morality. And I'm adding in morality here to say we can't just land on a Kantian categorical imperative type of logic, which tends to be more of an ethics frame. There are different definitions of good. How do we handle that? How do we think about that? And ultimately, this comes down to understanding values and principles, and then really it becomes a future orientation for our work and our thinking. How do we bridge this is an incredibly hard thing to work through. So, to end, what should we do? First, recognize there are some big questions and work on them. So let me just hit on 4. How might we improve professional scientists' awareness of systemic implicit biases that unintentionally may compromise our capacity to support those we serve with our science? How do we unintentionally compromise equitable participation, contribution, and a benefit from the applied sciences? How might we improve equity in science? How might we increase the trustworthiness of scientific consensus via diversifying people contributing and our methods without compromising our capacity to calibrate towards consensus? How do evidence and values interact effectively? How might we bridge is and ought thinking within the NIH and beyond? So those are 4 questions. But those are big, big problems. Let me try to make it more concrete. Another thing we can think about is the 4 pillars of power within the NIH, right? In essence, these things work synergistically together. You have methods, you have funding and amounts and study sections, and you have checklists on quality. This is good, by the way. When you think about power, when I think about power, I think a lot about trying to build countervailing forces. What are the checks and balances on these? Because I tend to start from the assumption that people want to do good. Most people want to do good, but they might not know, coming back to those variations that Camille was getting at, right? So how can we move forward and advance the types of methods and processes that could strengthen the trustworthiness of our scientific consensus and potentially allow us to start bridging is and ought thinking? And so here's some concrete suggestions for it. First, related to methods, create and expand on NIH-acknowledged best practice methods in citizen and personal science, along with open science practices. Particularly that last part of open science practices, there's a lot that professionals most definitely have a role within this. They build on our work, right? Dana would have never been able to build an artificial pancreas system algorithm without the companies building a solid continuous glucose monitor and an insulin pump, and she would never say she would ever want to touch that. She basically just realized computers do math better than she does, right? So that's what we mean by open practices. It's important for us to be sharing these things such that others can build on this work. 2, quality checklist. Build the appropriate checklist of quality that a study section could use to ensure rigorous use of these methods while not compromising fundamental epistemological requirements of a given approach. So what do I mean by this? There are different epistemologies on how we know what we know. Classic evidence-based thinking is grounded around the idea that clinicians know things and that prior knowledge knows things. But that prior knowledge is built on assumptions grounded on epidemiology, which is about populations. Anyone who knows anything about statistics knows that an average is not necessarily linked to a person. So there are other epistemologies that might matter. What do people learn from each other? What do people learn through self-study? How do we make sure that we allow those epistemologies to exist and not necessarily judging them on someone else's epistemology? You're not producing generalizable knowledge with self-study. That's okay. That doesn't mean it's not valuable. 3rd, study sections. Create new study sections filled with the diversity of citizen and personal scientists, plus traditional professionals, of course. And I would add sociologists and the humanities in particular into that, together to support rigor in this science. And last, because I'm almost done, build funding announcements that support a wider range, particularly participant-led work. And I want to end with, this is a movement Gary Wolf is moving forward on. Remember Article 27 of the UN. Everyone has the right to participate and share in scientific advancements and its benefits. Thank you.